All right, everybody, welcome to the Thorax 2 unit, and this time we'll be going into the lung viscera. So again, let's pay attention to our objectives when going over this, and if you have any questions, feel free to follow up. All right, so we already talked about the thoracic cage and everything that comprises that. When we open up the cage, if you're doing this, let's say in a cadaver or an autopsy, what you'll notice as soon as you open up the thoracic cage is you got these nice 3 compartments. We have our lungs on either side, and then there's a central area called the mediastinum. And so these are kind of nice little self-contained cavities that we'll see. So here's a nice little transverse view, and you can see in the kind of the colored outline how the cavities are a little bit separated. And we'll talk about how that works with the parietal and visceral pleura that do that. That kind of helps, especially there's a lot of motion going on in the thoracic cavity with our lungs expanding and contracting, our heart beating. So we want to make sure those things are like not getting a lot of friction, and these spaces help make sure that's possible. All right, so let's take a look at our lungs. When we identify our lungs, we'll notice that they have this nice little glisten to them, and that's because of the pleura. This is a membrane, and it's actually a twofold membrane. You'll see a similar thing in the GI tract with a serosa, so you can almost think of it like serosa of the lung, but we call it pleura. Now, pleura is divided into a visceral component and a parietal component. And again, if we want to harp on definitions, anytime we talk about viscera, that means on the organ or organ related. So viscera pleura is going to be actually on the individual lung. So when you see a lung and it's kind of nice and smooth, that's because of that visceral pleura. Now, the surrounding area, which we saw when we were looking at a cross section of our rib cage, is the parietal pleura. And so that's going to be on the outside here. Now you can see these are all continuous. So it is technically one membrane, but once it's on the organ, we call it visceral pleura. Once it's on the outer wall, we call it parietal pleura. And this helps provide some lubricant. So it's slightly serous coated, so that when the lung, and so here you can see collapsed lung, or basically a developing lung, over here is our inflated lung. This serous fluid actually helps lubricate the lung, so we can see that when it expands and contracts, we minimize the friction because it's just going to slide nicely along that pleura. The way I like thinking about this stuff is if you have a plastic bag or a balloon, let's say, and you start to blow that up, if you kind of were to stick an object, like maybe your fist or something, into the balloon, the portion of that balloon that's covering your fist is the visceral pleura. Everything else around it would be your parietal pleura, and then you kind of have this free space. So you can do that. You see it a lot with like water balloons and stuff, so I have some fun playing with that in the summer. But that's kind of the gist of it. So it creates this nice little pleural cavity, and we'll see that for both sides. The left and right, they're not communicating at all. And then when we get to the central component with the mediastinum where our heart is, we'll see that has a very similar structure. Okay, so here again is a basic outline of our visceral and parietal pleura. It can be a tongue twister, and they kind of just stop here at our hilum. We'll see the remnants of those structures as well. But again, both inflated lungs, you can see the outer side of our parietal pleura and the visceral pleura lining the actual lung structure here. Okay, so when we talk about the pleura, we like to divide things and make them a little more difficult than they need to be. We can actually divide the parietal pleura into 4 main components. And those components, it's not too hard to think about. They're just where that parietal pleura is attached to, right? So we saw the one that's going to be on the rib cage. So if you think about it, what one of these words looks like rib, costal. So there's a costal part, there's a diaphragmatic part, which is on the diaphragm. There's the mediastinal part, which is medial and going to be attached to the mediastinum there. And then you have a cervical part, which is going to be, or actually the cervical part is going to be up towards the spine area, right up here. And you'll see that actually kind of provides, it kind of pops up above. So if you were to get an injury around here, you could potentially risk injuring the cervical pleura and puncturing a lung through a neck injury. So it's kind of neat. We'll look at that when we can open up our rib cage in a little more depth here. So this is kind of just showing you, again, we looked at this in the last unit. You have your endothoracic fascia, which is basically containing all our musculature. And then outside of that, because the fascia is not going to be that much of a lubricant, we have our parietal pleura. So this is the costal part. The mediastinal part, you can just see here, kind of like that transverse image. We just saw the portion that's going to be lining towards the pericardium of the heart. Mediastinum, or the diaphragmatic portion, will be a portion that is just lying the bottom line of the the diaphragm, kind of just overlying that. And then the cervical pleura. So here's what I was talking about. So you can see how the lungs dip up above the clavicle there. So our lungs actually kind of go up. And if you're doing the neck dissection, it's kind of neat too. If we didn't, well, technically would have done the thorax unit first, but you can see the lungs kind of poking up through the neck dissection there. But this is just kind of a nice little clinical reference thing to be mindful of when you're thinking about things in a clinical setting, is that you do have portions of your lung actually outside the thoracic cavity there. We do actually have lines of pleural reflections. I'm not really going to test you guys on this. I think this is just kind of a nice to know. What this basically says is when we get to those different areas, the lines that basically make up that pleural, you see kind of shift, right? And that sort of designates where one pleural section ends and another begins. Really, it's just more of an anatomical reference point than anything. It doesn't have any clinical significance, so I don't think it's worth stressing about. But you do have a couple of those depending on where that line of deviation is going to split. So it's not necessarily like a smooth blanket covering your entire pleural cavity. It gets to a junction, does a hard right turn or left, if depending on the area, and basically becomes a new a pleural line of reflection in that, and that's all these are going to be really saying. So you can see a sternal line, which is going to be along your midpoint. The costal line is basically right at the edge of your costal margin there, and your vertebral is basically at the back, right before it dips back into your mediastinal component. So again, it just sort of is the boundaries of those pleural sections that we talked about. I wouldn't even stress about. I'm not even too picky on the various the pleural components, but I think they're worth knowing, and they're really not that hard to kind of be mindful of. One thing to note about the pleura, especially visceral pleura, is we can get cancer. So mesothelioma is a cancer of the visceral pleura, that membrane on there. And so you can see here, it's usually associated with some sort of asbestos, or even working in shipyards. People that had been working in shipyards for a long time will see these are increased risk for these cancers. But it's just a cancer of the pleural surface here. So you can see that our lungs actually look, and you'll have to trust me on this one, they look relatively normal. We got some anthracosis here, but you can see the pleura around that little outside structure does not look too pleasant. And that's all basically tumor that you'd have to go in and ideally resect or treat. Okay, so let's take a look at the occupying space. So we already talked about how our lungs are able to expand and contract depending on our thoracic cage, right? So the one thing to note though is even during complete inspiration, there's always going to be a little bit of a space. So if we're just breathing at normal capacity and we're not really exhaling, inhaling too fast, we're not running, doing our fight or flight or working out or whatever it might be, you're going to notice that there's going to be actual spaces present in the pleural cavity that the lungs don't fill up completely. Now, if I were to take a deep breath, I would fill up more of those, and I could probably minimize some of those diaphragmatic spaces or those pleural spaces. But for the most part, there's going to be some areas of just empty space. And that's good, because if we were to do something like a thoracocentesis where we actually need to get into thoracic cavity there, maybe if someone was dealing with like blood in their pleural cavity or fluid, you can drain that. A lot of times you can actually work in these areas of these pleural spaces. So we have a costal mediastinal recess, which you can see over here on the left side, and that's usually associated with along the mediastinum. And then both sides have a costal diaphragmatic recess. And so they're going to be dips on the lower side. And you can actually see those more prominent, and I'll get here, as you get towards the periphery. So you get these little pockets here. And that's kind of the area they would go to if they were going to do a thoracocentesis, where they would stick a needle into your lungs to try to alleviate some of the pressure there. So this is just a back view of that. But those bottom areas basically are, even during maximum inspiration, you're still going to have a little bit. So a lot of times if they needed to go in and sample that and take a needle into your thoracic cavity, they'll have you exhale completely, because then your lungs are going to be the smallest volume they can, and then they have a little more of that diaphragmatic space to work with. All right, so innervation. So the parietal pleura does get innervation. So we saw that the phrenic nerve actually innervates sensory for the mediastinal component. And then, as you might imagine, so we got that anterior rami of the spinal nerves, creating our intercostal nerves. That's going to be our costal component there. Additionally, we can get autonomic innervation of the visceral pleura. So the visceral pleura, this is all sensory for the outer side, for the parietal. So we can actually perceive pain and things like that, referred pain. But the visceral is all autonomic innervation. And so we'll see that with our parasympathetic and sympathetic reflexes for our pulmonary plexus. And the other thing to comment on is vasculature. Very similar to what we saw, again, if the innervation is going to be the same for the costal component, so is the innervation, the vascular. So intercostal arteries, both posterior and anterior, are going to supply our parietal pleura. And our visceral pleura is actually going to be partially supplied by some of our internal arteries, particularly like our bronchial. But pericardial cophrenic, that's one that we can see on the inside. It helps supply blood to our diaphragm. It also supplies blood to our middle component of our parietal pleura there. All right, so this is again going back. We got our lungs, we got our, right, left. You can't really see the mediastinum, but notice how the lungs kind of overlay that. You can see the startings of our pleural cavity here. This has all been reflected. So let's get into each individual lung and how to identify those. So first, let's talk about the surfaces of the lung. Okay, just like we saw with the parietal pleura, we actually have surfaces that we can use, and they'll have different shapes and forms to them. The easiest to recognize is kind of that concave section underneath. So you can see down here our diaphragmatic surface, and if you remember, the diaphragm kind of pushes up. It's that dome structure, so our diaphragmatic surface of both lungs kind of pushes up. It's got this characteristic indent to it, and then the lateral side, you see sort of this little outpouching. Again, you can see that how it would sort of try to get into those costal diaphragmatic spaces, but it doesn't hit them completely. The mediastinal component is the stuff that's going to have all your structures. So when you're trying to identify a lung, this is some of the best areas to look for. So the mediastinal is going to have all your vascular, the bronchus, pulmonary veins and arteries coming from there. That's all the mediastinal. And then and I use the term smooth loosely, but the outer component, that kind of like lung looking area, that's all the costal part. And a lot of times you'll see, you can kind of notice here, the artist did a little bit of a rendition with the rib imprints. So lungs are very squishy. They're going to get imprinted by all the structures that are surrounded by them. And particularly, if you fix these, they kind of become a little more permanent. But if you were to leave a fresh lung out, it could return to its normal expanded shape. But a lot of times by the time we get these, we see our imprints from our ribs, we see imprints from the heart, the thoracic aorta, and the aortic arch, things like that. Our lungs do have fissures. So in a very simplified version, for the most part, again, everything has to be typical, the right lung is going to have 3 lobes, and the left lung is going to have 2 lobes. Now, there are cases where those can be switched. They can both have 3 lobes. They can both have 2 lobes. The left lung can have 3 lobes, and the right lung can have 2 lobes. But you'll always be tested on typical structures. So just remember, the right lung is typically going to have 3 lobes, superior, middle, and inferior. And then the left lung is just going to have a superior and inferior. They both will have this oblique fissure, this nice little like slant that divides at least the superior and inferior lobes. But the right lung, in a typical lung, will have that horizontal fissure, which is going to separate the superior from the middle. Okay, so you got horizontal fissure, oblique fissure here. All right, so let's take a look at the basic anatomy and how to determine what your lungs which lungs you're looking at. Okay, so typically the go-to test question is you're given a lung and you have to identify is it a left lung versus right lung. So I know a lot of people are always like, does laterality matter? This time it does. So you can't just say lung. But a couple of things to help you determine which one it is the right lung tends to be a little bit larger. But whenever we're dealing with anatomy, I always encourage people not to think of things in terms of larger versus smaller. Everything is going to be relative to it. So if you don't have the left lung to look at, larger doesn't necessarily mean a whole lot. It is also going to be shorter and wider, just given the nature of it. But the dome is higher on the right too. So the diaphragmatic dome is a little bit more higher, and the heart is going to have a more imprint on the left. So if you think about, again, typical bodies, the heart is going to shift towards the left side of the body, and that's going to leave a bigger imprint. So we should see a minor imprint on the right side and a really big imprint on the left. So this is great if you can look at both lungs together and you're just trying to guess which one's right versus left, because notice here you can't really tell when you're looking at the mediastinal surface how many lobes we're looking at. So that's always the easiest, but if there's some sort of variation, the things you can rely on are some of these keyways. The hilum is probably going to be your best go-to if you're just looking at structures singularly. So if you're just giving one lung and someone asks you is the left versus right, the best way to do is go to the hilum. So that's where all your structures are going to come in, and that's what we're looking at here. So let's take a look at what to look for at the hilum. So both lungs are going to have a main bronchus, and we'll take a look at how that bifurcates and splits into the various lobes later. They're both going to receive pulmonary arteries, and those are going to split in a very similar pattern to the bronchus we'll see. They're going to have pulmonary veins, and those are going to be bringing the blood back to the heart, remember, and that's going to technically be oxygenated blood. Now the thing with the veins is it's not really helpful for orienting ourselves because they're so scattered. They don't follow the same path as the bronchial arterial trees, so it's not as useful. So what I always tell students is think of RALS, R-A-L-S. Okay, and what does that mean? It's basically you're going to look at the relationship from the pulmonary artery to the bronchus. All right, and so in RALS, it's right anterior, left superior. So in this case, our pulmonary arteries are right here. This is the anterior side, so this is towards the anterior portion of the body, and our bronchus is here. Now, depending on if you were to cut this perfectly, you would just see singular vessels, and it'll make things a lot easier. But a lot of times it's hard to do that because you have to get really, really close to the mediastinum to make a nice smooth cut. So you sometimes start to see the bifurcation. It's really hard to tell if it's a primary versus secondary, secondary versus tertiary. So the relationship you can always rely on, though, is our pulmonary arteries are going to be anterior to the bronchus in a right lung. And we'll see in the left arteries are going to be superior to the bronchus. Okay? Some of the other structures you might not really see, so the pulmonary plexus will kind of be in this area, and that's a lot of autonomic nerves that are going to help control some of your things like your breathing rate, dilation of your bronchioles and dilation of your blood vessels, things like that. The other stuff I'm not worried about. The pulmonary ligament you're never going to have to identify. It's just basically that convergence of your parietal and visceral pleura. And the same with the pulmonary sleeve, things like that. I wouldn't worry about that. Don't try to identify it. Basically, you'll just see kind of like a, what would you want to call it? A septum in the lung parenchyma. That'll basically be kind of that ligament and sort of the attaching point where all those parietal and visceral pleuras come together. So the things you need to focus on are bronchus, artery, and veins when you're looking at the hilum of the lung here. And like I said, you can kind of see the veins are a little bit all over the place. So when you're looking at a structure, and we can go into, I would work in looking at some of the images. Arteries are still going to have, if you remember the artery lecture I gave you, they're still going to have thicker walls. So at the end of the day, when you're trying to decide, bronchus will have cartilage. They'll be thick, but they won't have blood in them, and they kind of have little cartilaginous pieces. So get in the habit of looking for that. Whereas comparing veins and arteries, the veins should be very thin looking, okay? It should be very unremarkable, but our arteries will be slightly thick, maybe about 1 millimeter or 2, and that doesn't sound thick, but in anatomical terms, that's pretty good. So let's take a look at the left side now. Now we still got our notches and things that we can kind of look at, and if we're comparing the two, that's great. But like I said, you'll see a little bit of notches on the right as well. The one prominent thing you notice on the left though is this. So again, if you think about, and we'll look at this when we get to the heart, we got our aorta is going to come out of the heart, make the arch, and then drives down on the left side as it makes its way to the thoracic and then becomes the abdominal aorta. And you can see that impression in the left lung. Again, assuming everything is normal. So that's often helpful. For a lot of people, you can see that, but the impression might not be that significant. So again, you can go into the hilum. Other things of note is we do have a lingula on the superior lobe. So if we look at the superior lobe for the left side, there's actually going to be a little lip that comes down, and basically, like lingula just means tongue. It's going to be this little crevice that kind of sticks to the lateral aspect here and sort of just kind of hangs over and fills into that costal diaphragmatic recess that we looked at earlier. So it's not really prominently drawn on this image. It's basically going to just be like a little extra nip of the superior lobe that hangs off the lateral aspect of the tongue or the lung. Again, not a feature that's really great for identifying left versus right, but if someone were to ask you some of the key differences between the lungs, you can put the lingua as that. So what we're going to do is then look at the hilum again, the mediastinal surface. So the structures that, again, that I want you to worry about, again, that has all the similar stuff that we saw on the right, the ligaments and all that other fun stuff with the pleura coming together. But just focus on veins, arteries, and bronchus in this case. No nerves. You won't really see that. You'll see some nerve fibers from the plexus, but it's nothing that you'll ever really have to identify. So going back to my, whatever you would call it, keyword thing, my learning mnemonic. So RALS, right anterior, left superior, right? So that means the left artery, or the pulmonary artery on the left side, is superior to the bronchus. And in this nice little character drawing, here it is, pulmonary artery, bronchus. And these ones were cut very close to the mediastinum, which is good, so you just see singular vessels. It makes your life a lot easier if you were to do that. Again, I don't focus on the veins because they do kind of scatter, and even though it says like anterior most, inferior most, they can kind of be all over. I don't use those for orienting. I rely mostly off the bronchus and the arteries. All right, so let's take a look at the trachea now. So if we kind of so we looked at the bronchus that are entering into the lungs, we kind of merge those into a single point, we get our trachea. And you guys will look at the larynx prior to that, which is kind of the starting point of it. So trachea is this nice air tube that's then going to split, bifurcate into a left side and a right side. So begins at the larynx. It's got cartilage rings along the entire side of it. The back side has got these this muscular component, which we can look at here. It's got like a little muscular component that helps with the elasticity, and it's kind of just pressed right up against your esophagus there. And a lot of times you can actually see one of the common defects, I wouldn't say common, but an uncommon defect you can see in births is you can get a esophageal tracheal fistula, and there's actually a communication between your esophagus and trachea, and you can imagine that can cause a lot of downstream problems. But we have our trachea, that's the main thing here. We have our split point, and we'll take a look. This is referred to as a carina. And we have our right side, which is going to be very direct transport down. So remember, our right is going to have to eventually split into 3 different lobes, whereas our left typically only splits into 2. So we have a much smoother, kind of like shallower transition to the left main bronchus, whereas right is kind of just a straight down shot, and then it splits into the various lobes. Now, if you think about that clinically, if someone let's say a small child, a lot of the concerns, sometimes they swallow a coin or a toy or something like that. If it gets lodged in the trachea, and this is for anyone who accidentally swallows something, and if it does end up in your trachea, think about where it most likely will reside. Which lung is at greater risk for blockage? And the answer would be the right? So it's just a straight drop path to get lodged in the right side, versus the left, it kind of would like hit the carina and probably fall over, but it would have to require a little bit more lateral movement. All right, so here is a nice endoscope of this. You can see the trachea, and then we get to that bifurcation point, which we refer to as a carina. It's just a nice cartilaginous firm ridge. So if this was to be tagged, usually you see a view from above the lung. It's literally just going to be that split point right there. It's a nice dense cartilaginous segment. Here you can see it on the cross section here. So carina. So if you see like a little, well, usually we'd stick a pin in there if there's an arrow pointing to that. Think carina. Don't call it a trachea if we're showing you this specific section. All right. So I mentioned that the bronchus and the arteries kind of follow a similar path, and we refer to that as a tracheobronchial tree. All right. So for purposes of anatomy, you really just have to worry about primary bronchus. So we have trachea, primary bronchus, secondary bronchus, and tertiary bronchus. So each primary bronchus is just going to split to each lung, right? So we have a left primary bronchus and a right primary bronchus. And the secondary bronchus are referred to as lobar bronchi because they're going to go to the individual lobes, which means we have 3 lobes on the right side. We should have 3 lobar bronchi or 3 secondary bronchi. And then from there you'll get tertiary, which is basically kind of an expansion of those. But basically, after you see it go into the lobe and it splits again, then you can call it a tertiary. Whereas if we get to the left side, we only have 2 lobar bronchi. Those lobar bronchi are eventually going to split into what we call segmental. So you'll hear the terms segmental used synonymously with tertiary. You'll hear lobar used synonymously with secondary. And usually you just call primary bronchus primary. But once we split, the lobar are easy because they just go to the lobes, so you should always know that right has 3, left has 2. The segmental, I don't expect you guys to know the various segments. These come into play with surgery. So what this is, and because our blood supply is very much tied to our bronchial distribution, in surgery they can actually map this out and they take out these regions and have minimal effect on the rest of the lung tissue. So it's actually kind of nice to be mindful of these. We usually make our pathicist students be aware of this during the lung section because they'll be doing dissections on lungs in their lab. But for anatomy, just be mindful. These lobes, they can be slightly variable. And that's why it's not worth memorizing them, because you can usually it's usually about 10, especially when you're looking at the right, which has more, and the left side can have some variability as well. So just be mindful. This is what they're talking about when we start dividing in things into segmental bronchi. So you can see the various individual segments there. Eventually, this is more of a structure and function style question, but everything's going to keep splitting and splitting until we ultimately get to our alveolar. So we get our distal branching, and after several, when we call it generations, it's after several splits, we eventually get into what's referred to as our bronchioles. So you get conducting bronchioles, terminal bronchioles, and then respiratory. And these are microscopic, so you will not be able to see these in the lab or any sort of cadaveric images. These are when you're talking about the physiology of breathing. So our respiratory bronchioles are eventually going to give way to alveolar ducts, and then eventually alveolar sacs. And these are the things that basically, if you look at our like grapevine here, these are alveolar ducts, and then surrounded by alveolar sacs. And it's the sacs where respiration is going to occur. So the transfer of oxygen into the blood and CO2 from the blood into the lungs for exhaling. And so the goal here is we want to increase surface area. So that's why there's just a split, everything just divides. And so you get a huge surface area of all these alveolar sacs. At the most, just be mindful that they exist. Be mindful of the fact that bronchioles are composed of conducting, terminal, and then ultimately respiratory. But I wouldn't actually ever identify those. Couple of clinical correlates. So I'm sure everyone's familiar with lung cancer, relatively common cancer. We do have several variants. So you can actually get squamous cell carcinoma of the lung and adenocarcinoma. And what does that mean? Squamous cell, if you think about it, squamous cell is a type of skin cell, right? So it's an epithelial cell. In the lungs, we have epithelial surfaces on the bronchi. right? So a squamous cell will be developing from the bronchi, which is usually more centrally located, and then adenocarcinomas is a carcinoma of glandular tissue. And so that usually develops in some of the glandular tissue that we see around the lung, and so those cancers tend to be a little more peripheral. But so there's always more to it, and then you can get into small cell versus big cell. We'll save that for a pathology class, but just be mindful. Lung cancer is really just either a cancer of the bronchioles or a cancer of the lung tissue itself. If it's lung tissue, it'll be adenocarcinoma. All right, so let's take a look at the vasculature. These are pretty straightforward. So we kind of talked about the overall flow of blood in the body, right? So we know that the blood leaves the heart, deoxygenated blood leaves the heart through the pulmonary arteries and goes into the left and right lungs. And that's deoxygenated blood, even though they're called arteries. Now the blood's going to ultimately return to the heart via the pulmonary veins, which is oxygenated. So it's the only oxygenated vein in the body, just like the artery is the only deoxygenated artery in the body. And so the venous return is a little different, but the arterial flow that we looked at is going to be very similar to that tracheobronchial tree. So those arteries basically follow a very similar path that we would see with the bronchus. And so again, if we're going back to surgery resection, when we're looking at those segmental bronchi, if we know those segments, you can resect those and take the blood supply with them and have minimal effect. Unfortunately, veins are a little more complicated. So this kind of just reiterates what I was saying. So the pulmonary artery is going to divide into lobar arteries and then segmental arteries, exactly the same we saw with the bronchus. Now, what happens in the venous return is basically the septum that's lining all these segments just collects the blood after it's basically received all the CO2, or sorry, the oxygen, and then just eventually collects it further until it gets into the pulmonary veins and then dumps that into the heart. So it's not as a dynamic and easy to follow system. That's why I say it's not really worth trying to memorize the track. Just know that once your blood from the arteries gets to the alveolar region, it's going to get the oxygen and then just kind of seep through the septum of the surrounding area and eventually coalesce back into the heart via the pulmonary veins. The lung itself is going to need blood supply, right? So we talked about this having dual circulation. So the bronchial arteries are actually going to supply the hilar region. It's going to supply some of the visceral pleura. So we talked about the parietal pleura, which is going to be supplied by your intercostals as well as your pericardial cophrenic. But your visceral, your inner side of the pleura that's on the organ, is actually going to be supplied by these bronchial arteries. So eventually these will anastomose. So that's why we can see, if you remember what kind of infarcts, right, infarcts with anastomosis, bringing it all back, right? So, but their bronchial arteries are actually going to come off the surrounding arteries. So we see two on the left coming off the thoracic aorta. So that makes sense because that thoracic aorta is right on that left side. So we see a couple of branches coming off there. And then one primary branch coming off of the internal thoracic, the posterior intercostals from the right side. So those posterior intercostals still come from your thoracic aorta, but it's just an extra step on the right side because we now have to go through the posterior intercostal on that. So ultimately your aorta is going to supply, this is normal oxygenated blood to your hilar region and visceral pleura. Just be mindful of that. So again, there's a lot of variations. So 2 on the left versus 1 on the right is not too common. I don't know if I'd ever really test you on that number, but just know that bronchial arteries supply the hilar region and the visceral pleura. All right, innervation. So I mentioned the pulmonary plexus. So parietal pleura does have sensory innervation from the phrenic nerve and the intercostal nerves, but the visceral pleura is only going to be autonomic. So then we want to start looking at and same with the lungs too. So this is all an autonomic innervation. So the vagus nerve, which are going to be parasympathetic fibers, are going to be involved. If they get stimulated, that's part of the pulmonary plexus. Well, the sympathetic fibers are going to be part of that pulmonary plexus. The vagus will provide parasympathetic fibers to that plexus, whereas sympathetic fibers are going to come from the sympathetic trunk, create a plexus kind of around the mediastinum, and then supply sympathetic fibers to that. When we're talking about lung innervation, as far as parasympathetic goes, so again, that's active rest. So we want to be able to we don't need to worry about breathing so much. It's just kind of a passive process. We can rely on our basic diaphragm motion, kind of not even thinking about it. So what we do in that is we're going to actually see bronchoconstriction because we don't necessarily need a wide open bronchus, and we'll see contrast that to sympathetic fibers. It's not as prominent, and we'll actually see a vasodilation in that, and that's vasodilation for both our bronchial arteries and things like pulmonary arteries. So we're just getting normal blood going through, but it's not a matter of emergency. Now compare that to the sympathetic fibers, where you're actually going to get bronchodilation and vasoconstriction. Now vasoconstriction helps increase pressure, and pressure helps make things move faster, right? So when we're thinking about this is, if you're in sympathetic response, we want to breathe faster. So we're going to get more air into our lungs, so our bronchi are going to dilate. So you're stressing out, and we really want that blood to be narrowed and focused and just kind of like run through. So we don't necessarily need to worry about our bronchial arteries as much, and that's usually what's going to be mostly innervated by these sympathetic fibers. So we just want blood to be focused on our pulmonary artery and pulmonary vein system, rather than dealing with things like bronchial arteries and supplying the visceral pleura, because it's not as pertinent at that time. So keep that in mind. It'll be a little bit different when we get to the heart, but you should be mindful of the fact that parasympathetic is bronchoconstriction, vasodilation. Sympathetic innervation is vasoconstriction, bronchodilation. And that is it for the lung. So again, if you have any questions, thanks for joining me for part 2 of thorax, and we'll continue this on with part 3. Thank you.